Good morning, welcome to another NIPMED tutorials. Today we'll be talking about cesarean delivery. You know, for this cesarean delivery, there's this belief that this was how Julius Caesar was delivered, that Julius Caesar's mother, a knife was taken to her abdomen, cut her open and brought out Julius Caesar. Hence the name cesarean delivery. Some say it's because Caesar Augustus ordered the killing of the census, and then Herod wanted to kill the firstborn during the time of Jesus' birth, so it was called Caesar. We call it Caesarean delivery. However, whatever the origin of this thing is, it's not important to us. What's important to us now is the obs and gynae aspect. So Caesarean delivery is the delivery of the fetus, placenta, and membranes through a surgical incision made through the abdominal and uterine walls. Simply put. Caesarean section derived from the verbs that means to cut. Thus, the phrase Caesarean section is a tautology, so the correct term should be Caesarean delivery. So if your examiner asks you to talk about Caesarean section, say, "Sir, no, you are wrong. It's Caesarean delivery." So indications. Indications for every condition in gynecology is usually divided into three: the passage, the passenger, and the power. Passenger is the fetus. Fetal indications: fetal distress, especially in the first stage of labor. So when the cervix hasn't dilated up to 10 cm to allow delivery. Presence of cord prolapse. Cord prolapse is when the umbilical cord is the presenting part of the fetus after the membranes are ruptured. This abnormal presentation that persists after attempts at external cephalic version, such as transverse lie or oblique lie, when there's phase presentation, when there's multiple gestations. Usually, another way of classifying cesarean sections: relative indications and absolute indications. Okay, then you can then break this into relative fetal indications, relative maternal indications, so on and so forth. So, maternal indication: previous classical cesarean section, two previous lower segmental cesarean section. Classical is when the incision made in the uterine wall is what? It's a vertical midline longitudinal incision. If she has had two previous lower segment cesarean section, because there's risk of what? Uterine rupture. If she has had a previous uterine rupture, if she has had severe preeclampsia/eclampsia with an unfavorable cervix, using a Bishop's curve, so the cervix is not favorable for delivery, you want to go and do cesarean section. And previous extensive uterine surgery, such as myomectomy, in which the endometrium was breached, she needs to do cesarean section. Then obstructions such as tumors or fibroid, previous third-degree perineal tear and repair, previous reconstructive vaginal surgery, previous VVF repair, previous RVF, large vulvar condylomata, vulvar herpes simplex, because you don't want the child to develop touch infection. So maternal-fetal indications: cervical-pelvic disproportion, failure to progress in labor, is arrest of dilatation in the active phase of labor, major placenta previa, abruption with a live fetus. Abruption can lead to fetal demise rapidly, and absolute pelvic disproportion. Okay, absolute pelvic disproportion, CPD. So these are surgical approaches. Skin incision could be vertical or could be transverse. Each having different advantages and disadvantages. Vertical providing more access and room, but less cosmetic. Transverse more cosmetic, less remodelances. Okay. So it's got incision, sub-umbilical incision, but can be extended to the umbilicus. It is less vascular because it's along the linear alba. From the alba called white line because it has less vascularity there. But it gives good exposure to both abdominal and pelvic. Okay. So in emergency conditions with massive hemorrhage, we want to give a vertical incision. Fanesta, which is the lower segmental cesarean section incision. That's the classic one. See how early it came. Very, very early. So it might take a longer time to perform than the subumbilical and median vertical incision because it involves dissection of the anterior rectus sheath, and when extending to the external oblique muscles may result in injury to the linguinal and neogastric nerve. But this one is more cosmetically acceptable. Okay. So uterine incisions. The most commonly used one are the low transverse incision. Okay, it's lowest in the low transverse incision. A transverse incision done at the lower segment of the uterus. That is the one that's most commonly used in caesarean section. And the classical one is the one that is made longitudinally. So types of caesarean section. We have the classical one, we have the transverse one, we have the daily incision. Daily incision is like a lower segmental one but with a longitudinal incision. We have the J incision. It's a transverse lower uterine incision that is elongated to the upper segment on one end. So advantages of transverse incision over classical. Major advantage is the cosmetic one. Secondly, presence of transverse allows for allocation for a repeat vaginal delivery, for normal vaginal delivery, as opposed to classical, which doesn't, because there's more scarring than in classical. So less risk of entering to the upper uterine segment, greater ease of entering, less repair and easier reperitonealization, as covering it back with the peritoneum, less likely of adhesions to form to bowel as opposed to classical. And another thing, it creates room for us to have a repeat vaginal delivery. Less likelihood of subsequent uterine rupture during pregnancy. Okay. Lower uterine segment scars almost always rupture only during labor, but upper segment scars may rupture before labor and is certainly difficult to anticipate. VBAC is possible as vaginal birth after cesarean, especially if it meets certain indications such as weight being less than 3.5 gram, DTBM, the presentation should be what? Head presentation, these kind of things. And it must not have been a previous classical cesarean section. So once you meet the criteria for a VBAC, then you can go ahead. Technical ease of further dissection and lower intraoperative bleeding. The advantages of classical incisions. One is more access, rapid entry into the uterus. There's no lateral extension to the vessels of the broad ligaments. You understand? Because the vessels of the broad ligament enter the uterus on the lateral side, but in this case, there's no lateral extension. Alright? If the lower segment is fully developed, if the lower uterine segment is fully developed, delivery by the classical incision is advantageous without having lateral extension and easy entry. So complications, like I said, all surgical procedures, hemorrhage, anesthetic complication, and infection. These are the three major ones. So the anesthetic complication, pending anesthetic that is used. So immediate complication is primary postmortem hemorrhage, which can lead to anemia and shock. Hemorrhage is the most common cause of maternal mortality. Hemorrhage. Damage to the adjoining structures, commonly the bladder. The bladder is very common, and then also the bowel. Relatively common, the largeness, and the bladder is the most common. Other major organs such as blood vessels, strictures, ovarian fallopian tubes may also be damaged. Injury to the neonate, especially when you are puncturing your amniotic sac. Wound sepsis or infection, wound breakdown, endometritis, common in patients with prolonged rupture of membrane. Normally, people say before, prolonged rupture of membrane used to be like a contraindication to cesarean section, because when she has prolonged rupture of membrane and there's an infection, there's acute chorioamnionitis. You don't want to actually do cesarean section to reduce the spread to cause sepsis in the mother. But now, by the time you pack the paracolic gutters with gauze, that when you rupture it, especially the amniotic cavity, the gauze absorbs it to reduce the contact it has with the blood and other organs. Now, people go ahead and do cesarean section in patients that have prolonged rupture of membrane. But it increases the risk of endometritis and sepsis, and peritonitis, UTI, deep vein thrombosis, like all surgery. Now, long-term complication would the essence or rupture of the uterine scar and then secondary infertility due to severe intratubular or peritubular adhesions. Okay? Alright, good. Thank you very much. Then we'll see you next time.